Good afternoon, everybody. I would like to request the friends, those who are sitting in the rear part, can come forward. Now the chairs are empty. And before I begin, I like to thank the scientific committee IOC for having me allowed to run this course. And as I tell you, this is the most important part because whatever best, however best you do phaco surgery, but there are situations and probably we face a lot of problems. So common, manageable, but still it's a huge, many patients now, they complain that there is some problem, though the surgery has went very well. So I am very happy to uh, introduce my team to you. We have Dr. Rajiv Chaudhary. He is a very renowned surgeon from Indore, and he will be covering the most important part, disturbing symptoms following uneventful cataract surgery. And then we have Dr. Amrata Sharma. She's very busy. So we have asked Dr. Shubhita Nair to cover the corneal issues in spite of the uneventful phaco surgery. See, Dr. Shubhita, please come on the dais. Then we have Dr. Mayuri Kumar. She's a very renowned glaucomologist from Ahmedabad. So she will cover this raised IOP part and how to manage. Then we have Dr. Harbans Lal is not coming, so I will cover his part, the how to handle the refractive surprises. Then we have, of course, this is me. I will manage that. And then how to manage the small position, the IOL, and of course Lalit Verma, they have a very important session there in other hall. So the vitreoretinal issues will be handled by Dr. Vinit Shah. He is also a very good speaker. I then assure you both of these. So, and then if the time permits, we'll go for the panel discussion. So I'll ask Dr. Rajiv Chaudhary to start his presentation, please. Please come, Dr. Kamar, Dr. Raj.
Hello. Uh, Good afternoon. Uh, my topic is the disturbing symptom after very good cataract surgery. What are the reason and how to deal with it? Even with technical perfect outcome after cataract surgery, still patients are unhappy. And there are multiple visual complaints as we know all faces day to day. We six patient is 6, but he is unhappy. We are happy, but he is unhappy. In majority of cases, the proper conversation with patient can fix the source of unhappiness. We can realize what is his problem, what are his expectations. Sometimes they might be having an unrealistic expectation, which we have to overcome. Common disturbing symptoms are regarding refractive outcomes. Sometimes they are unhappy with your 0.25 correction, dysphotopsia, which is one of the more common cause, and dry eye. And sometimes rarely the patient come with the drooping of the lid. Now, come to the refractive surprise. When to anticipate refractive surprise? Extremely myopic, hyperopic eyes, very large, very small eyes, post-RK, PRK, LASIK, post-PK patient, especially post-RK patients. There sometimes you get a very unpredictable result even after calculating all type of the power from all of the recent formula, because that are not, and we in Indore, because we have the majority of RK patients, we are facing more of them. Most common cause, limitation of precision and accuracy of biometry, especially in high myopic and high hypermetropic eye. Inherent uncertainty of IOL power calculation formula due to unpredictable final effective lens power. Imprecision determination of corneal power due to previous keratorefractive surgery. Variables such as capsular bag diameter for which no precise and practical measurement technique exists. Tear film abnormality, SPK, sometimes PCO, cystoid macular edema, capsular changes, capsular constriction can lead to forward displacement of IOL and can lead to the myopic shift. So sometimes you get a refractive surprise. What we can do? We can correct with the glasses, contact lens, corneal refractive surgery, lens exchange, piggyback. There are the multiple options. Then we have to overcome this. Want to do with refractive surprise? Stay calm, be patient, advocate, and don't let the situation become adversarial. Preoperative oil counseling can help prepare patient for surprises, especially multifocal. When we say the multifocal, you will not get glasses for distance needing, and if your counselor has pushed him forward more, we will be in trouble. So always under promise, and always I say to my patient that these are the possibility, but you will get some number for distance and some number for near. And if he didn't get, then he is more happy. So this type of symptoms you can see, glare, halos and starburst. Many times patient complain कि light चमकती है, ये होता है. What are the positive? Bright artifact of light, halos and arc causes higher refractive index of the lens, square edge lens, decentered IOL. Negative is a temporal. Many times patient come, there is it's moon-like shadow on the temporal side. These are the negative dysphotopsia. Small pupil, large gap between iris and intraocular lens. There are multiple other causes of dysphotopsia, tilted intraocular lens. Sometimes one haptic is in the bag and one haptic in the sulcus. Misaligned toric IOL, posterior capsular opacification, square edge lens can give the glare, surgery-induced astigmatism, and the postoperative dry eye. So needs preoperative workup, treat ocular surface disorder first. Then we go to the aberration. What are the optical aberration? Lower order, higher order. Spherical aberration occur when the light rays are over-refracted at the periphery of the lens. In normal population, mean corneal spherical aberration is plus 0.27 to plus minus 0.10 micron. Corneal spherical, so you have to select the lens. Corneal spherical aberration plus value, negative defocus, posterior, best vision. Corneal spherical negative, positive defocus. So this help in the choosing the intraocular lens, whether we have to use with a spherical zero spherical aberration or the minus spherical aberration or so these are the lenses which are having the Alcon IQ has a positive spherical aberration. Otherwise AMO, Bosch and Lomb, they are the minus spherical aberration. Technis and Bosch and Lomb is the zero, which we can measure with the pentacam, eye trace, and different equipment available for the measurement. Assess the angle kappa, especially for the intraocular multifocal lens. What we use once you get in a spherical aberration or this glare and halo, a repeated assurance to the patient. A counseling, gradually the brain get adopted, and it takes 2 to 3 months to get adopted to this spherical aberration or dysphotopsia. Then another option, give the spectacle which is slightly thicker frame. So it obstruct the peripheral rays coming to the area, and then symptom gets reduced. Correct dry eye, and if the refractive error is much more, correct that also. During surgery, well center in the back, you should keep in mind, ask the patient to stick to see in the light center of the lines, and then your lens should be the center there. So this is one of the important point, especially for EDOF and multifocal lenses. Brimodine and pilocarpine drops in positive dysphosphopsia, in some cases it helps. In the second eye, then you consult and switch to the round edge or silicone lens edge or plate haptic lenses which have the periphery lens material also. If it still persists, you can exchange that after 3 to 6 months. Don't mistake this photopsia with the PCO. Evaluate posterior capsule first thoroughly before yaw capsulotomy. This is one of the interesting case. Monofocal lens, patient was not compared. I will show the eye trace also. All is well, but still I rotated this. It is a monofocal intraocular lens. AMO lens, and after, sorry, I will show you the rotation. Just we have rotated this because there was the capsular fibrosis. We have rotated this lens and prevented the fibrosis. And now you see that upper eye trace is the preoperative. Patient was definitely 6'6", Technis lens, but you can see in the eye trace that there is an halos and glares are there. You can see this. This is the images. These are the aberrations. And after rotation, that you can see patient was happy, and now you see that it is all because that monofocal lens got slightly tilted because of the capsular fibrosis. These are giving the aberration. So his problem was benign. He was with the 6'6" vision, but his problem was benign, and if you assess that what is the cause of the error, you can correct it. Treat the ocular surgeon. So time is short, I will go short. So treatment, assure the most topical lubricating for the dry eye, punctum blood, dry eye tearing. Now the lid ptosis. Ptosis, sometimes that patient come with the, because of the overstretching of the superior rectus, topical anesthesia, risk of ptosis is decreased. Still occur in significant percentage of patient. Eyelid speculum, stretching, retrobulbar block, sometimes this can lead to the lid drooping is often short-lived. It can correct in the 6 months. Aprocolindin ICU up to 2 millimeter of lift. And if it is persists, you have to go for surgical take. So in short, take home message, dry eye problem before surgery, protect endothelium, conquer Jernicke's lower order first, good evaluation and intraoperative management of astigmatism, correct aspheric IOL selection, and correct selection of multifocal IOL can lead to a good outcome, and you can consult your patient very well and patient can be happy. We cannot give 100% result, but then we can increase the percentage of our success. Thank you.
Thank you very much, Dr. Chaudhary. And I would like to add one more thing. Those who are doing under peribulbar anesthesia, sometimes, the ecchymosis, the black spot, blue spots, the patients are more concerned about it rather than the vision. So again, the counseling and that is more important. We don't want to add any other treatment, but that is very important. Thank you very much for nicely covering this topic. Now we go further. We request Dr. Shobita Nair Shah to allow us to help and how to make these patients happy if they have some corneal problems. Please.
A very good afternoon. At the outset, I would like to thank Dr. Ashok Shroff sir for giving me this opportunity to give this talk today. So my topic is what are the corneal issues that we encounter in unhappy patients post an uneventful cataract surgery, and how we can go about preventing it or treating it. I do not have any financial disclosures. So the causes of unhappy patient in postoperative period can be divided in the immediate postoperative, that is on the day 1 or 2, and in the week 1 or 2, or maybe in the late postoperative phase. So as a cataract surgeon, after an uneventful surgery, what we look for is a clear cornea, an IOL in place, a happy patient, and a 6/6 vision. But the first thing that scares us is to see the corneal edema on postoperative day 1. So most common cause for the corneal edemas in the postoperative day 1 phase is when we operate on hard cataracts like brown cataract or mature cataracts, where we use high phaco energy, more phaco power, or instrumentations are entered into the eye multiple times, or endothelial touch happens. The IOP can raise, because of which epithelial edema is seen in the immediate postoperative phase because of retained viscoelastics, retained lens matter, or when we deal with pre-existing corneal conditions, especially Fuchs corneal endothelial dystrophy, where there is corneal gutte and there's chances of corneal edema developing in the postoperative phase. Descemet membrane detachment, which is not noticed on table, and we get to know it on the postoperative day 1. When there is wound leak, there is hypotony and presence of DM folds that occurs. Epithelial defect that occurs because of inadequate proper placement of the speculum or while removing it, or overhydration in diabetic patients where the epithelium is loose and we can develop a defect on the postoperative day 1 or 2. And lastly, TAS, that is toxic anterior segment syndrome, because of the inflammation that happens. So when we handle, when we operate on patients with brown cataract or mature cataract, it's very important to do a good pre-op evaluation and a planned approach, so that the patient is well counseled, and even if edema occurs, they know the recovery time for the visual recovery can take some time, and they are mentally prepared for that. So we need to use a dispersive viscoelastic to coat the endothelium. The phaco power and time should be kept in check, and any unnecessary entry or exit of multiple times the instruments inside the eye or endothelial touch should be avoided. And if any edema occurs, we need to treat it with hyperosmotic agents and steroids to control the inflammation. And of course, the newer agents now, that is a ROCK kinase inhibitors like riposodil, plays a very good role for endothelial regeneration. So the raised IOP because of the retained viscoelastics or lens matter can be handled by using IOP lowering agents, topical steroids, and to do an AC wash to remove the cortex or the lens matter. Most common corneal dystrophy, that is the Fuchs corneal endothelial dystrophy, uh, has a very typical beaten metal appearance because of the corneal guttae seen in both the eyes. So we need to do a good preoperative slit lamp evaluation and counsel the patients accordingly. A preoperative specular microscopy helps. If the counts are less than 1500, there is greater chance that you can develop a corneal edema. It can also go into decompensation. As USG pachymetry, if the pachymetry thickness is more than 620 microns, again chances of corneal edema postoperatively is high, so the patient needs to be counseled accordingly. So we need to keep a check of the phaco power and the flow rate. And of course, if edema develops, we need to go for with hyperosmotics and topical steroids. Usually Fuchs not easily missed because of the significant guttae that we see, but sometimes some patients have just minimal guttae or fine guttae which are scattered around. So it's very important to do a good slit lamp examination in all of our patients, taking some time about it. A Descemet membrane detachment which is missed in the initial phase can be seen postoperatively. Sometimes if the edema is very high, we can go for anterior segment OCT to know the location and the extent of the DMD, which needs to be managed immediately surgically so that there's better chances of attachment of the Descemet membrane and visual recovery is much better. Wound bone which occurs because of the poor wound architecture, we need to address it immediately. Otherwise, it leads to wound leak, hypotony, and DM folds which persists for quite some time. Epithelial defect also needs to be treated accordingly. So predisposing factors mostly for DMD is age. Dense arcus patients who have dense arcus are also prone to develop Descemet membrane detachments. If there is a history of DMD in the other eye when operated for cataract, there's more chances that this new fresh eye which you're going to operate again has a chance of DMD. So the site of DMD, at what step it occurs, commonly during the entry or during wound hydration, it is important to intervene as fast as you can, because the earlier the DM gets attached, the better chances that the edema resolves faster and the visual acuity is not affected. So either we can use air or gas, that is 14% C3F8 or SF6, as well as or suture can also be used. So there's an entire protocol, that is the HELP protocol, based on the height, extent, length, and pupil-based measurements, based on which, whether it is planar or non-planar DMD, we can plan medical or the surgical management of Descemet membrane detachment. So the toxic anterior segment syndrome, that is any inciting agent should be avoided, and usually there's a limbus to limbus corneal edema with sterile hypopyon and a dense fibrinous membrane, which usually presents within the 12 to 48 hours postoperatively, which usually responds very well to topical steroids. It's important to differentiate it from immediate endophthalmitis. So in the week 1 or 2, we can have a DMD which develops little later, or it's missed in the initial phase thinking it's just a corneal edema and we are treating with hyperosmotic agents, and later on once the edema settles down, we are able to see a Descemet membrane slightly detached in the periphery. So it can be noticed in the week 1-2 also. Again, the line of management goes according to the HELP protocol. The corneal wound entry, if it becomes very anterior, it can lead to irregular astigmatism, which also causes glare and other dysphotopsias. Corneal epithelial toxicity, because of the multiple topical medications that are used, if they are not used preservative free or over medicated, then can lead to punctate epithelial erosions, which also causes patient discomfort. faint DM folds which are persisting for a long period of time, and raised intraocular pressure because of the steroid responders. So in those cases, we can use low potent steroids like 1% loteprednol also helps with controlling the inflammation. So the DMD management, according to the health protocol, we should go for a good bi or triplanar corneal wound constructions, prefer preservative-free topical medications. Cornea has a good healing capacity, so give time for it to heal. Do not over-medicate the patient unnecessarily, and a good IOP management. In the late postoperative period, we can have the wound scarring because it can lead to higher order abrasions, which can also cause astigmatism. The corneal astigmatism component with the rule against the rule should also be treated in picture. Surgically induced astigmatism should also be consist. And most common problem, that is a foreign body sensation, which persists for almost 4 to 6 weeks post-cataract patients. In most cases, the pre-existing dry eye should be looked into. Any corneal infections that can develop in the later period because of long-term use of topical steroids should also be taken into consideration. So reassurance is the key in most of these cases, a good dry eye management, astigmatism management, and corneal ulcer treatments. So in brief, to conclude, I would like to say that important takeaway points are: approach cases in a conservative manner and treat the cause appropriately, correlate the visual acuity with the anterior segment appearance, listen to patients patiently, and maintain an open communication. They're coming to you even after 6/6 vision. That means there's some amount of discomfort that they have. Most of the times, a good reassurance and increased chair time clears all the problems, and they do not go doctor shopping to treat their problems.
Yeah.
Timely referral to senior colleagues or corneal and retinal surgeons also helps in treating most of the problems and give a good symptomatic relief as well as a good visual acuity. Thank you.
Thank you, Dr. Shobhita Shah. Thank you very much for covering so many issues regarding the cornea. And this is all we know, that the budding surgeons, no, who are in the initial life of their surgical life, means they face a lot of problems. So you have to ensure the patient. That is what we want. We have to ensure the patient and counsel the patient very well. And once they are convinced, nothing goes wrong. However, for some time, for a few weeks, if these conditions are not cured or covered up, then it is better to refer to a specialist for the further evaluation. And once we get the vision better, of course, and whatever challenges or whatever errors have been made during the first surgery, if you can cover it up during the second surgery, it goes well. So the new surgeons, you must make sure. But over a period of time, once you become senior, nothing will happen to you. Thank you very much. So we go further, we go to Dr. Mayuri Kamar for unhappy patients when they have elevated IOP. Dr. Kamar, please.
Lecture here. I will start with a case of mine, 48 years, young male who has a poor diabetic control, had both eye fully mature cataract, had PDR with a laser PRP was done, and the intravitreal injection was also given. He underwent an uneventful Phaco with IOL using Helon and between the 3 days interval, and post-operative day 1 in both eyes was within normal limit. After 3 days of the second eye surgery, left eye surgery, he came suddenly with the sudden onset of severe eye ache, headache, and severe diminution of vision. The vision reduced to counting figure 2 feet, and he has a very, very shallow anterior chamber, no cells, no flare. Convection color was also not seen. The injection mannitol was given as the pressure was 54 millimeter of mercury after consulting his physician. And daily it was given for 3 days, but the IOP never came down. All the suggested treatment was given. And this is the anterior segment OCT picture as well as slit lamp examination showing you an inflammatory membrane, giving the pupillary block mechanism, and a very, very shallow chamber. But IOL you can see was way behind. So it was a typical pupillary block syndrome. So what to do here? So I'm going to talk on the elevated intraocular pressure making your patient unhappy after the surgery. Post-operative raised IOP is common, but majority of the cases are asymptomatic and it is transient. The peak IOP between 30 minutes to 4 hours after surgery is a common thing. IOP greater than more than 28 millimeter of mercury was seen in 18 to 45% of the cases. The glaucoma could be primary pre-existing glaucoma or it could be secondary, and primary glaucoma may be newly diagnosed or missed before you do the cataract surgery, and secondary is usually related to the cataract surgery, early onset or it could be late onset. Why there is an unhappy patient? Because there is a mismatch between the expectation and the outcome. You are doing a premium IOL, patient is expecting a miracle, asymptomatic post-op, early rehabilitation, and decrease in the number of medication if he is a known case of glaucoma. But outcome is different. Patient is now symptomatic. It could be in form of pain, watering, redness, narrowing of the palpebral fissure, and suboptimal vision. As I said, the early onset IOP rise is usually secondary in nature. The etiology can have a various mechanisms like retained OVD, inflammation, lens debris, or pre-existing glaucoma. And mostly it is the aqueous humor flow drainage obstruction, and diagnosis mainly is clinical. The treatment should be individualized according to the etiology and try to avoid the PGs and pilocarpine in this case. Big no to them. Initial therapy is to control the IOP medically. One can use topical and systemic aqueous suppressants. Timolol, brimonidine, and are preferred over the carbonic anhydrase inhibitor. And cycloplegia, use if you have a dilemma in the diagnosis. Subsequent management can be in the form of laser if it is a pupillary block, SLT for open angle glaucoma, and surgery is the rarity which is required in these cases. So coming back to the patient I started, so we lyse the membrane with the YAG laser, and you can see that immediately after the laser there is a deepening of the chamber, and at the end of 1 month everything was quite and patient was happy, we were also happy. Vision 624 was because of the bad macula due to diabetic retinopathy, but the IOP was normal, patient was off the treatment. Another cause could be the hyphema. Here also it usually self-limiting and resolves without any complication. Paracentesis is rarely required, and start using the aqueous suppressant with the corticosteroid. This is very commonly seen these days as we all glaucoma specialists are doing GAT surgery when we do the cataract surgery. And GAT as one of the main complications is the hyphema. May not be on table but can happen after 2 or 3 days. Uveitic glaucoma is more common with the pre-existing uveitic or complicated cataracts. Then here also the corticosteroid plays a main role. Control it by using the oral systemic or the topical corticosteroids in more doses. Cycloplegia is must, and iridectomy sometimes is required if there is a pupillary block mechanism. The pupillary block can be there in the early phase, but I have seen many patients coming after months of cataract surgery with the pupillary block mechanism. Most common cause usually is with the angle closure glaucoma following cataract surgery, and can occur in the presence of even peripheral iridectomy. So may present days or weeks following the surgery. Iris bombae is a typical sign with the elevated intraocular pressure and occlusio pupillae. So the management is try to dilate the pupil first, and then if it is not happening, you have to do laser iridectomy, and then IOP reduction medication should be started. Another case I would like to mention, uneventful surgery. On 4th day, patient came with acute headache and blurring of vision, and all the treatments were given by the treating doctor. He was referred to us for the second opinion. Iris surface, if you see carefully, the black pigments all over were seen, and gonioscopically, the TM was showing jet black pigmentation in 360 degree that was giving the obstruction to the outflow facility. So diagnosis was severe inflammatory response, and pigments black, we suspected ciliary body was affected. Now pre-existing glaucoma patients where the cataract surgery were done, there is always a risk of bleb failure. And the management is again a medical therapy. But the counseling should be done in these patients that they might observe the rise in intraocular pressure following the cataract surgery. The malignant glaucoma can occur if patient has angle closure glaucoma, which is a high risk here. And degree of the angle closure, how much was there at the time of surgery, will also give you some clue how much is the risk. And it should be differentiated from the choroidal detachment or pupillary block or suprachoroidal hemorrhage. The management for me, if it is early case, atropinization is must. Patient may have to use this for a long period or sometimes even lifetime. And YAG laser can be used to disrupt the anterior hyaloid phase. You may not do it in the center, can be done in the periphery if there is a PI pattern. Through that you can do the hyaloidosis. UGS syndrome is not seen these days a lot. It was because of the imperfect selection of the IOL design or improper placing of the IOL. Here it is shown that one haptic is in the sulcus and other in the back, and this was giving him a high pressure. So repositioning or removing of the implant and doing again can be of help in this case. One should not forget about the PACs. Though patient may not have a rise in intraocular pressure, but in their lifetime it can happen. So counsel the patient regarding the lifetime follow-up. And gonioscopy is must when you do the traumatic cataract. Look for the angle recession or the synechia. Again, they are advised for the lifetime risk of developing glaucoma. In pediatric age group, incidence of glaucoma following congenital cataract surgery range from 1 to 32, but remember, the risk of developing glaucoma after pediatric cataract surgery continues throughout the life. And these are the factors which can give the high risk factor. So in end, what patient doesn't know, surgery is routine for us, but it is once in a lifetime experience for patient. So even a small pain or foreign body sensation should be addressed immediately. Patient will interpret as a complication. He is not expected to know something as benign as a foreign body sensation or not aware that blurry vision may occur after surgery. So reassurance goes a long way. There is always a fear of vision loss when they know about high intraocular pressure. So clear communication, counseling will always save our life. Patient education should be done before the cataract surgery, and prompt intervention should be done. One should be patient to listen to them and always have a positive office vibes, because as soon as patient enters your office, he will start evaluating everyone. So thank you very much.
Thank you, Dr. Mayuri Kamar, for your excellent presentation. Now I'll be covering two topics. Number one is how to make, how to tackle the refractive surprises after even uneventful Phaco. So the reasons for this may be some ocular diseases like corneal opacity, silicon oil, where your calculation, means our calculation may not be correct, or there is a history of RK, PRK, LASIK, and in that case also your our calculation may not be that precise. Maybe you have old generation biometers or maybe improper application of the newer formula. So these are the reasons you may find some refractory surprises when the patient complains of blur vision. So again, in that case, must go through thorough clinical examination of anterior segment, pressure, and IOL position. Any inflammation or infection you should look for, and you have to manage it accordingly. Careful refraction is very important by yourself or a very talented optometrist, and rechecking the preoperative data. You must recheck whether there was some error there at that time. And you must discuss with the patient very politely. You must check the method of drug application. When the patient is putting the drugs, we have seen many times that they put the drug on the cornea and don't keep the eyes closed for even seconds, and so the medicines don't go proper. And the proper explanation about the neuroadaptation, particularly in the premium lenses, is very important. Frequent follow-ups. If there is a problem, it is better you ask them to come a little more. नहीं उसको मालूम है और मैंने देखा ही नहीं यार. Okay, thank you. So frequent follow-up is important because if suppose the patient has poor vision on the first day or second day, and then once you 3-4 days after the vision is improving, the patient is also happy, and if necessary, you must go for the another surgical intervention, if necessary, and that time, make sure that if possible, we don't charge the patient. Now the management, there are different options. Either, as Dr. Chaudhary said, dialing of the lens, particularly in the toric cases, if the axis is not, then the axis of the lens is not properly placed, or if the refractory error is significant, then you should go for PRK or LASIK. And I mean, if you have to go for intraoperative maneuveration, then you have to exchange the lens. Piggyback lenses, it has been in practice, but I don't know whether they are not very popular. And use of new oil calculation formula, particularly when you have these histories now, you must have these new formulas with you. See, this is PRK and LASIK is very easy and safe. Particularly, it should be done after when the refraction is stabilized. Again, you must treat this as a new procedure. So proper preoperative workup to follow all norms, pre, intra, and post-operative care, so that you get better results. A very interesting case of male, 50 years. He had a posterior polar cataract. The right eye had 6.6 with 0.5 diopter cylinder, and the left eye again 6.6 with plano. But the near vision was 6.6, and with the addition of 1.5. Preoperative IOL master 500. You see the K1, K2 axial length. The Phaco was done with panoptics. See, vision 6.6, but here problem because of posterior polar cataract. And then when the IOL implanted, 21 diopter, post-operative correction was 6.6 with -2, spherical and 1 cylinder. How can be happy a patient? It is but natural. The near vision N6 without addition. So I had to go for LASIK surgery after 3 months, and of course then it was 6.6 plano and N6. The second eye, when he came for the second eye, so again we have calculated the IOL power was plus 18, but this time it was done on IOL master 700, and which could give correct calculation even in the presence of posterior polar cataract. And you can see the postoperative visual acuity was 6.6 and N6. So these sometimes the experience gives you some lesson how to manage. Now there are other reasons when you have to exchange the lens. There may be marked decentration, gross residual error, and significant night vision issues with multifocal IOLs. You know, very important incidents has happened with a very Bollywood star when this one implanted and a lot of issues. Anyway, major surgical intervention, it is better to do early. It's difficult to put multifocal IOL again in the bag. So therefore, you can go for foldable in the sulcus. Make sure that the adhesions are cleared first, and then you have to dial. And in that case, you can go into the sulcus. It is a rigid lens which was put. Then, because it was a corneoscleral incision, so it was easy. We did not want to cut, and the IOL was explanted as it was. And then again, the second IOL of appropriate diopter was implanted. Here, it was a foldable lens, so we could cut it into the anterior chamber through almost the same wound. We did not enlarge, and you can see that the lens was explanted in one piece, but making the two pieces of the two cuts in the lens. Toric IOL, when they are grossly disturbed, when it is not properly aligned, the dialing of IOL as early as possible is a must. So the take-home message, for the refractory surprise is common post-Phaco, very common, and more so at particularly with patients that disturbed when you have used the premium lenses. But of course, many times it settles of its own. Polite counseling is very important in multifocal, and proper preoperative counseling, LASIK is better option, but you have to be prepared to face the music. So we go to the next. Malposition IOL. Okay. In spite of enough care taken during the IOL insertion, IOL can be found displaced during the follow visits. It's more common with learning phaco surgeons. Malposition of IOLs are not appreciated by patients if the vision is not disturbed. They don't know it unless your next doctor, next door doctor reveals it that the lens is not properly placed. There are reasons. You have a large size eyeball like very high myopic, or you use small IOLs. Intraoperative pupil becoming small and you are in the learning phase, initial phase of your practice. At that time, because you're in a hurry, probably the anesthesia is fading away, then it is possible that your implantation of the IOL is not proper. So these are but the improper placement can be either the one haptic is out of the bag or in the anterior chamber, improper centering, particularly for the multifocal or the EDOF lenses, improper axis alignment, again when the pupil is becoming narrow, or anterior bulging of the lens in the anterior chamber due to the uncleaned visco left behind the IOL, particularly the heavy visco. So how to manage it? These patients are unaware about it unless the next doctor, as I told you, it reveals it. Vision is, this is very important, what I've seen in my practice. Vision is not compromised. Explain to the patient before somebody else tells him. Explain, but no active treatment is required. The patient is concerned with the vision. So better explain, be honest. If it is displacement or malposition, a little bit, but the angle kappa is not disturbed, the visual axis is going through vision is okay. Explain, tell them honestly that it is better. On the contrary, you will win the confidence of the patient. So the counseling is very important. And if you need to do second maneuveration, please do it as early as possible. But again, at that time, you have to take all precautions. See, you see the case report, a very close family friend of ours, the left eye phaco IOL done, Alcon panoptic story implanted, and post BCVA was 6'9" with minus 1.5 cylinder 140, and near vision was N6. See, I'll show you. You can see here if you can. See, this is the multifocal. I mean the panoptics. But you see, during the implantation, something went wrong, and here is this is the. Anyway, you see the line there. There is a posterior capsule gap. So it was very difficult. Again, we could not dial. So in that case, patient was happy. I explained the patient, we can do it. We can do the LASIK if you want top up. But the patient is happy, no, I don't want to do anything. So it was an explanation from my side that this is a position. So the patient accepted gracefully and okay, fine. So the management, suppose we want to do, we have to go for active management. Then the dialing of IOL, proper dialing of the loop. So because most of the time you need to manage the loop, or dialing of toric IOL in a proper axis. At the most, at times, you need to go for exchange. Now this is what you see here. The lens has been, of course, it is a referred case. I think hardly 10-15 days have passed after Phaco, but it is not uneventful Phaco. You can see that because I found that there was a little vitreous into the anterior chamber, and it is difficult to dial the lens into the sulcus as it is. So we tried to do that. It was easy, but then additional anterior vitrectomy was necessary. And once it was done, then it was easy. You can see that, see the margin of the posterior capsule. And once it was easy, then we dialed the patient. And now normally what I've seen, that dialing the lens with the anti-chamber maintenance is easy rather than the pars plana infusion. This is how done. You again here you must be slow, careful, and you must take enough time to place the lens properly. There is another case, again a referred case. There are a lot of capsules, and you can see the tear, and the lens has been displaced, decentered grossly. As it was a rigid lens, it was easy to dial, and we just wanted to make sure that the loops are free and in the sulcus. See, it's not easy. So we did the anterior vitrectomy. You can see the vitreous little bit, the visco into the vitreous chamber. And once the AC was clear of the vitreous, then it was easy. To summarize, the cautions during the preoperative, before the surgery is very, very important. And thorough examination is very important, and you must select the IOL properly. Intraoperatively, you must position the IOL in the bag or in the sulcus. And to manage the small pupil, if need be, you have to use either the iris retractor or the capsule care. And the honest counseling and second maneuveration at an early stage is very important. So to take home the message, to avoid such situation, be careful during the surgery, operation. Pupillary management is very important because we have seen that when these residents are learning or in the initial phase of your practice, this can make a problem. And if vision is not disturbed, just watch, don't do anything. Secondary intervention at an early stage is very important. Thank you very much. Now I invite Dr. Vinit Shah for the last part, how to manage the vitreoretinal issues. Dr. Vinit Shah.
Good afternoon, everyone. Thank you for attending the lecture after your lunch. And now we'll speak about the retinal issues which the patients face after an uneventful phacoemulsification surgery. So in my initial days, this was like this when I came out of the OT. Next day or after a week or so, when the patient is always complaining about visual complaints or some other discomfort, and we are confused what has gone wrong when the surgery was absolutely fine. So like everybody has said, it is divided into early and late phase. So in the immediate post-operative period, the problems which patients might face is post-operative iritis, the TAS, endophthalmitis, and the pre-existing retinal diseases which were missed during the initial evaluation before the cataract surgery. So post-operative iritis, many a times we get severe inflammations in patient where we find fibrin membrane and pupillary block kind of a syndrome, which is covered by madam very well. So in such cases, stepping up the topical steroids for the patients and adding cycloplegics helps resolve the condition within a few days. When it comes to TAS, there is corneal edema, there is hypopyon, there is FM, and there is a quiet eye apart from these syndromes. So in such cases, it is important to differentiate the TAS from endophthalmitis. So TAS typically presents with a blurry vision. It is usually 20 to 48 hours after the surgery, and we find corneal edema. Whenever it is there, it is limbus to limbus edema. And when it comes to endophthalmitis, the main patient symptom is pain, usually 4 to 7 days after the surgery, and there is focal edema. So this is a case presented 4 days after the cataract surgery, which was uneventful. We can see there is conjunctival injection, hypopyon is visible, lid edema is there, and when we see there is discharge and matted eyelashes. So this points more towards a picture of endophthalmitis, and on B scan we can see there are vitreous echoes, not seen very clearly here in the picture, but there was a component of vitritis also present in the patient. So such cases needs to be referred early to the retinal surgeon, and once it is referred, an early prompt treatment usually gives a very good result. So when it comes to endophthalmitis, we all know preoperative povidone iodine is the first line. Intracameral antibiotics are effective, and especially now we are using moxifloxacin. Previously cefuroxime was used, but now the organisms are resistant. And topical antibiotics usually lack any proven benefit when they are added perioperatively in a patient where the patient develops already intracameral antibiotics are used. We do use it routinely for all our patients, but the studies have not shown any added advantage when we are using intracameral antibiotics on the table during the surgery. And preoperative topical antibiotics we all start because we all are afraid of endoff, but studies have shown, at least in the Western literature, that there is no role of preoperatively starting topical or oral antibiotics in the patient where it can reduce the risk of endophthalmitis. So in the late post-operative period, we can have chronic low-grade iritis. So this is a treatment algorithm which I follow. In such patients, there is usually after 6 to 8 weeks after uneventful cataract surgery, once the steroids are tapered, they again develop iritis, photophobia, pain, and defective vision. So in such cases, we usually restart the post-operative steroid, and usually in a higher dose, maybe for 2 hourly, then slowly taper it over weeks. And when the inflammation is very mild to moderate inflammation, we usually go for a 6 weeks to 8 weeks of steroid taper. Then after 6 weeks, when we are seeing, there can be 3 scenarios. Once there is no inflammation and we can gradually stop it. Second is recurrent inflammation, and third is rebound inflammation. So once the patient had settled after 2 to 3 weeks, and then again there is a rebound iritis. So in such patients, going for difluprednate or a higher steroid rather than prednisolone has a better penetration and has a better action than predford. So in such cases, also giving dexamethasone intravitreal implants can be helpful when it is recurring. In the initial stages, we can also give a posterior subtenons injection at your side where the inflammation gets controlled better. Then everybody talked about glare and negative dysphotopsia, for which the retinal surgeon gets a reference. The patient is complaining about something seen. The anterior segment surgeon doesn't see anything in the retina or in the vitreous, but the patient continuously complains. And mostly in the causes which Rajiv sir had explained, there is an illumination gap when the light passes through the IOL and through the edge of the IOL. So there is a gap which is not illuminated properly, which causes that crescent-shaped gap and a shadow in the vision. So in the early phases, early days, it is due to corneal edema, large angle kappa, or IOL designs. This usually subsides over 4 to 6 weeks to 2 to 3 months. And orientation of optic-haptic junction in the infratemporal plane is also being mentioned as a cause. All these features usually resolve after 3 to 4 months and just need reassurance. But if the patient is persistently complaining, we can go for reverse optic capture for such patients to reduce the distance between the iris and the IOL in the sulcus. So this can reduce these symptoms. PVD. Mostly my referred retinal patients are post-cataract for PVD. Patient is complaining about floaters. Usually self-limiting. After a month or so, the symptom subsides because the brain adapts to that. But retinal evaluation by a specialist is required because we need to look out for any retinal breaks or any lattices or holes which have opened up due to the PVD. Treat the retinal breaks, and oral medication now available for vitreolysis, And YAG vitreolysis can also be performed when the floaters are large and only in the central area. And if the persistent complaints for the patient, we can give an option of vitrectomy for the patients. Coming to CME, which is most commonly seen, preoperatively the cornea, the retina was normal, then there is a edema. So the risk factors are uncontrolled diabetes, ERM which is missed early, diabetic retinopathy patients, and glaucoma patients who are on prostaglandin analogs, they have higher risk of developing cystoid macular edema. And when cataract surgery in the previous eye also had a history of CME, such patients we need to counsel them beforehand that your other eye surgery can also present with cystoid macular edema post surgery. Treatment is again topical steroids and NSAIDs drops which we are giving. A posterior subtenon steroid injection helps a lot. And if after all this, if it doesn't resolve, then we can go for intravitreal steroid injections also. Usually I wait for a month for the symptoms to resolve just on the topical steroids as well as NSAIDs. And once it does not resolve, even after that, we can go for intravitreal or injections. Now, worsening of pre-existing retinal disease. Diabetes is known to progress after a cataract surgery, and patients with mild to moderate NPDR can develop cystoid macular spaces post-cataract surgery. And this also resolves nicely with our topical steroid medication. We need to wait, we need to give it time to heal. Just the patient needs to be explained about this condition. So many times due to dense cataract and poor visibility or dense PSCC, we are not able to find the subtle macular holes or ERMs beforehand before advising the surgery. In such cases, we might get unhappy patients post-operatively, but that needs to be explained to them whenever we see a hard cataract case where we are not able to assess the fundus properly. And there was a controversy regarding age-related macular degeneration progressing after doing a cataract surgery. But the recent studies have shown that there is no association between cataract surgery and wet AMD progression. So even after doing a cataract surgery, AMD will not progress. At least the patients do get a good vision after cataract surgery because the media is clear. But there is no association that doing a cataract surgery will worsen your wet AMD. Obviously, it has to be treated and there should be no fluid before we go for a cataract surgery in such patients. But it doesn't worsen what was previously believed. So thorough retinal and macular evaluation for patients with before cataract, effective preoperative counseling with, and setting realistic expectations like everybody said, and timely referral to a concerned specialist can give good results. Thank you.
Thank you very much. Thank you very much, Dr. Vineet Shah and the panels. So let us go on the front part to have the photograph. Photographer, please. Welcome, Dr. Azad. Actually, we were given the mic half an hour late, but still we are almost on the time.
बत्तेरी